Oh, there it goes. It's recording. All right. So today, thank you everybody for coming to Pandemics, Plagues, and Public Health. We'll be discussing different things such as the Spanish flu of 1918, the public health issues in Albania, and then of course the opiate crisis, which is at times, sometimes like drug addiction is considered a plague or some sort of pandemic because of overdoses and such. People do die from opiate use. So today's presenters, all undergraduate students, are awesome history students. Yay! Today presenting is going to be John Foerster, Ediola Malkouari, and Andrew Kishuni. And I'm sorry if I messed up your names.
That's good.
Yeah. Okay, and we're going to begin with John Foerster. So who is my student and has been for the last 2 years, and he's going to be presenting today about the opiate crisis.
Hello, everyone. I will start by sharing my screen. This is a poster I utilized for my surf conference last summer, so some of the information is a little less current, but I think that it was a good stagnant image considering that I don't have a wallpaper. So I will be going over a very basic speech structure about my research, and then if there's any time left over, because I'm timing myself for the 10 minutes, I'll go back and bolster some of my previous points with extra information. So my name is John Foerster, and I am currently a UCF senior. I've been conducting a thesis project with Dr. Panetta, as she said, for just under a year at this point, and that's what I'm here to present to you all today. My research revolves around the U.S. opiate crisis and the experience of both the professionals who work to assist with addiction treatments, as well as recovered opiate abusers as well. Specifically, I researched medically assisted treatment centers, MAT for short, around locally centered areas and contrasted those perspectives with those held by others within a similar field. Namely, I utilized ethnographic research methods to complete a series of 12 interpersonal interviews from all walks of life. We had recovered opiate addicts, MAT Center directors, MAT Center employees, doctors, pain management specialists, former Purdue pharmaceutical affiliates, and a variety of others with both professional and personal ties to opiate abuse. The main purpose of this method was to firstly diversify our accounts and develop a more holistic perspective, but secondly, to develop a foundation towards understanding what the U.S. opiate crisis is, where it comes from, and how it's impacted our country. For the purposes of today's speech, I will be going over 3 main points. The first is a bit of background on this topic, where I will share with you all a few of the disturbing reports felt within recent years. The second is how the experience of recovered opiate victims contrasts against those professionals in the field. And finally, I will move towards analyzing some of the arguments for and against the U.S. opiate crisis, whether or not it's truly considered a genuine crisis, and share my final opinion on this based upon my research. So before jumping into the statistics on opiate and painkillers, let me begin with an ode to American addiction rates. According to the University of Southern California researcher Jessica Ho, the United States is in 2018 ranks as #1 in the world for fatal drug overdoses. Not only does this mark the 10th anniversary of the United States sustaining this rank, but it ranked 27 times higher than in Italy and Japan, who are the lowest ranks, and double the rates of Finland and Sweden, the second and third ranked countries respectively. In 2017, addictions to tobacco, alcohol, and illicit drugs, according to the National Survey on Drug Use and Health, 27.8 million Americans who are smokers, 66.6 million Americans are monthly binge drinkers, and 30.5 million have used illicit drugs within the last month. When relating this to the overall population of the United States, this means that 38% of all Americans are currently living with an addiction to a potentially life-threatening substance. Now moving to opiate painkillers. In 2014, according to the Substance Abuse and Mental Health Services Administration, there were approximately 1.9 million Americans who met the criteria for prescription painkiller use disorder based on their prescription painkiller use within the last year. Only 3 years later, in their 2017 report, there were an admitted 11.4 million people in 2016 who misused prescription painkillers. This increase of 9.5 million people represents a staggering increase. These statistics represent an increase in prescription opiate misuse, alluding to this phenomenon's pharmaceutical origin. This means within a period of roughly 5 years, the United States has accrued more opiate patients than the entire population of its most populous city, New York. Within my own research, I developed the following methodology to look towards how treatment centers fit into these trends realistically and on the ground. I utilize ethnographic research methods prominent within anthropology's delves into the realm of substance abuse narrative. Specifically, I utilized many aspects of DeWalt and DeWalt's participant observation and Fetterman's ethnography, both cornerstone texts for ethnographic methodology. So, what did I find? Let's begin with medically assisted treatment centers. The role of morality within medicalization was apparent throughout the time I spent within the MAT center I worked with. For one, while there are a variety of drugs available to help treatment opiate withdrawal, their reputation comes to incite moralistic arguments. What I mean by this can be best seen through methadone, the most common opiate treatment medication. Regardless of the fact that the medicalization mindset has been rising since the late 70s and early 1980s, there is still a negative connotation attached to methadone considering its perceived synonymity with opiate addiction. While this is actually quite ironic, considering that methadone cannot be abused in the ways that opiates can, methadone functions by filling the opiate receptors within the brain, thus not allowing them to feel any effect from other opiates. Given the nature of this drug effectively filling the receptors it does produce reports of a high, yet not to the levels I've seen with intravenous heroin use or high doses of orally ingested opiates. All in all, these treatments, if taken daily, as many are recommended to be, amount to a total monthly cost of $500, which is a lot to place on any US household. Interestingly enough, none of the recovered opiate heroin addicts I interviewed during my research ever stepped foot into a methadone clinic, choosing instead the options of quitting cold turkey or traditional rehab, which blends into my next point regarding opiate victims' experiences and applying them to a theoretical framework. I identified 3 theoretical frameworks that my research findings have found. For one, Lefebvre's spatial theory blends perfectly into the MAT Center conundrum, considering that even though the MAT centers I worked with had, and I quote, 67% non-Hispanic whites, they were located in the center of one of the largest Hispanic working class neighborhoods in Orlando. This in turn generates a discussion about what society deems as good and right space and who has access to it. For even though these clinics are frequented by white Americans, they are not being placed within predominantly white neighborhoods, given their proclivity to be affiliated with social ills of chronic drug addiction. The concept of opiate abusers being labeled as socially deviant is only a result of our understandings of them, and that is what this research is working towards. I remember an impactful quote from one of my respondents, Ernesto, when he told me about what living with opiate addiction and finding his friend overdosed in the streets was like. And I quote, "I found one of my friends when he was doing a lot of heroin. I found him in a garbage can. Well, you do not know about those garbage cans. They were the metal that they put in front of the building, and he was head first, half of his body in the garbage can with a needle stuck in his arm, dead." And as horrific as this story is, it only serves to highlight the harsh realities felt by those within substance abuse tendencies. And instead of viewing them as the cause of social ills, this research instead would like to look at them as an effect of the harsh realities of drug abuse. Excuse me, I appear to have lost my spot. Okay, these realities are both deeply profound when one considers that a large portion of Americans with access to regular physician and higher-end health insurance can afford to simply go to the doctor and get prescribed these medications. It's only those who do not have those kinds of health insurance or income qualifications that end up within methadone clinics. And given the long and historic documented history of healthcare inequalities for racial and ethnic minorities in the United States, it becomes even more egregious to consider that at any rate, the majority of those found within these clinics are still white Americans. My final framework comes in the form of Spivak's classic piece, Can the Subaltern Speak? And within my own research, I had 2 large findings as it relates to feminist theory. These 2 were that the relationship between the severity of the drug and its affiliated level of patriarchal dominance, and that the culture associated with drug use heavily mirrors the dominant one in terms of its relationship with women. Spivak argues about the exclusion of the family as the part of the masculine frame with which Marxism marks its birth. What this means is that the family is such an instrumental portion of the Marxist viewpoint on the political economy that merely replacing the family will not break the frame. The argument here is that society falls within the bounds of popular practice and culture, and given that patriarchal dominance is a present issue within the dominant culture of the global north, it can extend both up and down the rungs of social ladders, extending even to drug-using subcultures. And as such, removing the person from the family does not decrease the reality of female oppression under a patriarchal system. It simply morphs its nature from one oppressor class to another, further delegitimizing women's place within the political economy of drug-using communities. And so given these 2 frameworks, we can then move forward to discuss as to whether or not these spikes in opiate drug use do qualify as a genuine crisis. For one, there is certainly an argument to be made regarding the US tendency to overlook demographic differences when attributing attention to crisis. An excellent example of this can be seen with popular media portrayals of a similar crisis in the 1980s seen through the US crack epidemic. On screen right now, I have juxtaposed on the left, this is the cover of Times in 1991. It says, crack kids, their mothers used drugs, and now it's the children who suffer. On the right, this is a 2018 article regarding motherhood while addicted to opiate painkillers. The similarities between these are none, and the differences are far-reaching. But what do these two pictures unpack for us? Let's see. Right. The main argument here is that the U.S. opiate crisis is only deemed as such because of its primary effects against white people, and as such, the media blows these rates out of proportion. While I personally believe that the racial component of this crisis is understated and must be taken into account, there are still components of this event that stand out as uniquely imperative. For one, white Americans overdose at rates 50% higher than African Americans and 167% higher than Hispanics. However, opiates are the leading case of drug-related deaths among all races and ethnic groups. So this is not necessarily only a white American issue. The other reason given is that this is, is actually put forth by Dr. Andrew Kalandi. He explains that the same racial discrimination that disproportionately targets African Americans for being drug abusers within the United States is also the very same one that prevents them from gaining access to prescription opiates. He explains that doctors prescribe narcotics more cautiously to their non-white patients, and as such, the Black patient is less likely to be prescribed narcotics and therefore is less likely to wind up becoming addicted to the medication, in a profoundly ironic reality present within the United States. Therefore, I leave you to ask yourself whether or not the U.S. opiate crisis could be considered as such. The only stipulation for your answer would be to ask yourself, crisis for who? Thank you.
Let me see. Perfect. Thank you. You stayed to your
yeah, I went a little bit over.
Wow, like a few seconds. It was right on time. Good. Thank you. All right, our next speaker is Ediola, and she's going to be talking about public health issues, including social stigma, drugs, and other public health like COVID in Albania. You're muted. Oh, there we go.
Okay, so can you hear me now?
Yes.
All right. Greetings, everyone. My name is Ediola Malkouari. I'm a history student, and I'm working with doing the research with Dr. Pineda. It's been almost a year now. It was last May when I went to Albania to conduct my research in social stigma and substance use disorder, and how that was affecting Albanian public health, and why it was considered at times a plague for the society. So I would like to start my presentation by a map where Albania is located, and is sometimes like in different studies, like in in the World Organization, sometimes Albania is referred as the Western Balkans, or as Southeastern Europe. And depend on the studies and depend on the information where you look at, even though there is some studies done about Albania, which is about Albanian demographics and Albanian demographics, and life expectancy, and information in general, which I have published here in this poster. There is not much information about how it is, Albania as an ex-communist country, how the public health is affecting Albania, what kind of public health do we have, and what is the reality the individuals who live in Albania face every day. And therefore my focus was to present in more details that is not just about the numbers, but it is it is also like what kind we are considered to have a universal healthcare, which it is considered a universal healthcare with a form of Shemoshenko, which comes from the Soviet Union form, and still this universal healthcare is supposed to have like the insurance booklet provided by the state, and all individuals from birth to an older age should be covered by it. But yet most of the people, like it, from 60 to 70% of the people, they do pay out of pocket, and some at times it is considered that it is not just for the fees and paying the doctors, it is also considered payments that are done in the directly to the doctors or the nurses in order to receive a better treatment, or for them to pay more attention. Yet after the transition that Albania went through from the end of communism in 1990 to today, a lot of doctors and a lot of nurses and like the brain power of Albania, they have immigrated in different countries, and that have taken a big toll in Albania too. So last year when I did my research in Albania, my research was especially focused in the substance use disorder and how social stigma was affecting the substance use disorder. And this is my poster that I presented at FARC this spring, and like all the pictures that I present in the middle are called like traditional dressing of Albania, and like pictures of me while I was doing the research, and the individuals that were part of my research helping me get the research in Albania. And some of the things, the methods that I used to conduct my research were by doing interviews, and the interviews were focused in four different groups. The first group was with the close relatives who were like helping people who were recovering or were still going through the addiction process. The second group were medical professionals, which in specifically were doctors, like a ER doctor, toxicologists who are closely treating patients from substance use disorder, a nurse, and psychologist as well. And I was able to interview 3 individuals who were in a process of recovering from heroin, which is considered one of the deadly drugs in Albania. And the stigma for this drug is much higher. And that is another part that I would explain later. And there were 6 individuals which have used different mixes of drugs, and they were still users. So, as I mentioned earlier, the types of drugs that were used, or people like would talk more in Albania, were heroin, which was considered as the individuals who used heroin, they didn't have no, or people didn't want to be around them, didn't want to have any interaction with them. Even their own family members had a high stigma towards them as well. And the other individuals who used other drugs, from cocaine, ecstasy, LSD, and other synthetic drugs, that at times they weren't sure what kind of synthetic drugs or what kind of drugs were all mixed on the cocktails they were using. And they knew that the drugs would have some effect on their body, but yet they weren't ready to give up the drugs. They were the ones that mostly didn't want to tell their families that they were using drugs. They were the one who would use the drugs going out with friends, or like in a certain places, in clubs, or in vacation homes, away from their families, because they didn't want to face the stigma of their parents having towards them, or their partners in the cases when they were married or like engaged and things like that. On the other hand, like the light or the medium drugs, which are considered sometimes as a teenage drugs or like very light drugs, were the opium poppy, marijuana, and things like that. And alcohol and tobacco were not considered as like drugs, or they were considered something that, oh, it's okay, it's normal, it's part of our culture. So for initial findings that I found in Albania during the research was that individuals who suffered substance use disorder, they were deprived of the proper medical care attention because of the stigma, and at times, for example, the LGBT community or females would face a harsher stigma, because females are the one that society considered to be the one who is like they are the one who holds the family, they are the one who reproduces, like they give life to the family, and they are never seen as someone who can do such a bad thing as using drugs. And on the other hand, LGBT community, in one hand, presenting themselves to their family as homosexual, not heterosexual, that is what everyone expects them to be, and using drugs is like two beds at the same time, increasing the stigma a lot higher, and they have been mistreated and abused by police, by individuals in the road, if they know like they are using drugs, and like from the society in general as well. And most of the treatments in Albania are only for like heroin users, and the heroin users, they would get the treatment by the Action Plus is like an organization who gives the treatments by like the methadone, and they do not have like a special quote of how many people they can accept. There are nine centers across Albania, and they in general they do help around 800 people, with those focusing 220 only in Tirana, in capital of Albania. And when I interviewed the director of this clinic, he said that of the organization, I'm sorry, he said that 7 to 8% of individuals were females. So I would like to, what does that mean now that Albania is going through a pandemic? Sorry, guys. So as today, during the COVID-19 outbreak in Albania, there were 518 cases, 26 of them were fatal, and there were 20 new cases today. And as for what is known now, Tirana is the epicenter of COVID-19, which is the capital of Albania, as I mentioned earlier. And as I was asking on the interviews that I conducted during this time with medical professionals, they said that they did not have any N95 masks or like any special mask. They would wear 2 or 3 surgical masks, and they would have like the robe that was special, but this was used mostly by the epidemiologists who would go to the families or to people who called that believed that they had COVID-19. They did not want to leave. They did not want these people to leave their houses, because as I mentioned before, Albanian healthcare system does not have all the materials and all like the technology needed to comprehend this great outbreak that is making like all the countries suffer and everything like that. But what does this mean for our patients who are suffering from substance use disorder? As I was talking to the doctors who used to treat those patients in methadone treatment, they said that they were not any specific cases or any special actions taken by the state to help those individuals who had suppressed the immune system. And the only one who was helping during this time was again the Action Plus, the organization who kept their doors open to do the methadone treatment, and they were taking actions by advocating and by providing information to their patients and trying to help them as much as possible with the psychologist and other individuals that would be there for them if they had if they're going through a crisis and things like that, with Zoom meetings and FaceTime and what they could. So,
all right, thank you, Ediola. Yeah. I wanted to add, she didn't mention, this research is still ongoing. So the reason she added COVID, because your graduation date is in fall. So while she's doing this research, COVID happens, and it's like, oh wait, I'm in the middle of what's going on with toxicology and substance abuse. I'm like, wait, now they have a new issue on top of it. So that's why, we agreed that it's probably an important issue. Major pandemics are usually major issues.
Yeah, sorry, I didn't mention that. I was just trying to get, because it was all the information together and trying to add all of them in the 10 minutes.
Okay, all right, so we have one more speaker, and then after that we're going to have plenty of time for questions. We have until definitely till 6:15, which will give us a nice 45 minutes or so to do it. So our next speaker, Andrew Kishuni, he's also a history department major. He's working on the pandemic of 1918, and just in having short conversations with him about his research topic, it's absolutely fascinating. And he's, I guess maybe during the QA, you can find out all about how he's done his research. And I think you've done this research for the past year, right, Andrew?
Yeah, I began the project in spring of last year.
Okay, fantastic. All right, so please tell us about your project.
Okay, I'm gonna set my time, that way I don't go over. So my name is Andrew Kishuni. I've been working with Dr. Lester on on the 1918 Spanish flu, or the misnamed Spanish flu, because it actually emerged from Kansas. The flu pandemic of 1918, it killed between 50 and 100 million people worldwide. It's considered the deadliest pandemic in modern history. The flu did in 4 weeks what it took the Black Plague 240 years to do, what it took AIDS 24 years to do. It killed 675,000 Americans in about a month span in October 1918, and 4,114 Floridians. It begins in March 1918 in Haskell County, Kansas, in rural Kansas. And it spreads from the military bases in Kansas, Fort Riley, with the Army Training Center that's there, and goes towards the eastern coast and the Atlantic to go overseas, because this is, of course, the final year of World War I. And the Germans have launched their spring counteroffensive. And so they're kind of the final battles are going on. They know the war is going to end at some point, but they don't know when exactly. So Americans are still going there, and they're taking the flu with them. And when they go, the flu enters its first wave. It's first of 3 waves. So the first wave ends in June, and people believe that it's just a flu, and there's nothing unique about it. And then it resurfaces. It's unknown how it resurfaces. Some epidemiologists believe that the flu is actually, that pandemic was broken up into 3 different variations of the flu. Some think that it was the same strain that simply amplified after sweeping over battlefields in Europe. So that's what happens. And then in around September, it resurrects and comes back as demobilization begins on U.S. troop ships, comes back to the United States, and back into ports. So the first cities that report it are, of course, port cities. You have Camp Johnston in Jacksonville that reports it, Pensacola, and the military bases there. That second wave is the one that is lethal and the one that everybody remembers. And then, of course, the final third wave is in January 1919, and it's kind of similar to the first wave. There is some heightened mortality that isn't like other flu epidemics or pandemics, or flu season in general, but it isn't the second wave. The second wave in October is the worst one. And that's the one where most public health officials are documenting mortality, and that's where my project comes in. So I focus on that wave, that second wave of the flu pandemic. I focus on that wave in the South. And my research is about poverty in the South and underdeveloped public health infrastructure and the impact of the flu on race in the South. The first history of that pandemic is written in 1961. There's a good chunk of time that historians don't really build any basic scholarship on the pandemic. That's usually relegated to physicians and statisticians who are trying to piece together the flu pandemic because they're afraid that it's going to come back. And so historians, of course, they're more focused on events that have human agency and not pandemic. So the war takes kind of the historical spotlight, and the flu is kind of forgotten. But in 1957, another flu pandemic happens. And so in the 60s, they begin to work on this. And of course, there's the social turn, the cultural turn. And so social history becomes prominent in historiography, and historians begin looking at the flu. And their assumptions about the flu was that it was a great equalizer, kind of like how you hear people talk about the coronavirus pandemic, that it killed without distinction, it was a democratic killer, and that there was no difference in the way the flu impacted or inflicted mortality on different subsets of the US population. My research focuses on the South to try and dispel that myth of the democratic killer flu. I look at public health reports from the period, and I reconstructed the statistical epidemiology of the flu and its distribution and mortality between African Americans and white Southerners. And I found that more African Americans died of the flu in proportion to their population sizes in the South than whites in the South did, in most cities. There's issues to that, though. Part of the methods that I used couldn't break out poor white people from the chunk of white people that are reported in the official mortality statistics. But certainly poor whites died in similar ways to African Americans. So just for the sake of time, my thesis, I defended it and submitted it to STARS yesterday. It takes place in Jacksonville, New Orleans, Savannah, and Nashville. But for the sake of this meeting, we'll only focus on Florida. And let me see if I can share the screen properly. I will show something I had done in Dr. French's class, Digital Tools for Historians. Here is my Florida project that I did, kind of a secondary thing, where I tried to highlight that differential mortality in across Florida counties. So there are 54 Florida counties in 1918 compared to the 67 that we have today. So that's what explains this kind of, if you can see my cursor, this kind of gray area here. Some of these counties didn't exist. They were actually part of the other larger counties. But part of this project was to show further that the myth of a democratic killer flu is a myth. And part of my argument is that there are no democratic pandemics. You will always see a disproportionate impact on the poor and the marginalized, and those who are, I don't know how to put this, oppressed under the biopolitical death grip, if you will, of inequality and inequity in the country. So this is just an example of what this tool can do. And if you're interested in seeing the tool, I can send you a link. I'm also working with Kirk Lundblade to try and see if we can get this on the riches database. And I put this together with a friend of mine, Jesse Campanella from Tennessee Tech, who showed me, how a Tableau works, and I work with Dr. French to try and make it functional for historians. But if you would hover over, let's say, Duval County, which Jacksonville is a city that I talk about in my thesis, you would see that I used mortality rates instead of the raw mortality data. So mortality rates, they're preferable to raw data because instead of focusing on how many die, you might have 100 people in a county and you would have maybe 50 white people and let's say 30 black people, and maybe 20 are a mixture, immigrants and things. You would have maybe 20 of that 50 of whites die. And then you would have 15 of the 30 black people die. So to a health officer who's looking to make his city look appealing, and of course there's a certain racial narrative going on too, it would appear on the surface that the white people had died more in raw mortality. But when you put them over when you put the deaths over the population size of the respective race, it'll show something like what you see with going on in Duval. So white mortality is 7.2 per every 1,000. All mortality rates are typically computed per 1,000 persons. The black mortality was 8. So they died slightly more in Duval. But in some other places, like Osceola County here, I don't know if you can see it properly because this thing is, move this down. Osceola County here. So white mortality was 2.3 per every 1,000 and black mortality was 10.6 per every 1,000. So only in 13 Florida counties did white Floridians die more or have higher mortality rates than African American Floridians. Let me check my time to make sure. Okay. And I'll wrap it up here. And so here is something like some comparative where you can compare black and white, and you can see obviously density in the areas, especially port areas, where the flu is coming back during the second wave to military bases and things like that. And then I think I also have a heat map in here that shows the concentration of deaths in the area. And I'm planning on updating this. I was in contact with John Barry and Mark Honningsbaum, Margaret Humphreys, big medical historians who work on the flu and work on the history of pandemics. And they would like to see age and time also included in this because the flu was unique in that it killed those between the ages of 20 and 40, those who typically would not die of influenza. Usually influenza kills the young and the old. But this pandemic was bizarre. It seemed to take advantage of young people's immune systems and cause what is called a cytokine storm, where the immunity is so robust, they're trying to fight the virus by making cytokine cells, and those cells then drown the patient in their own fluid. Very similar to what is happening with COVID-19. And that's a brief introduction to my research. Thank you.
All right, thank you. Thank you. Okay, thank you everyone, all for the speakers. I really appreciate you all were able to stay within time, which is very unusual for historians. That's wonderful. Okay, so now we have I guess we have 30 minutes open for questions, all Q&A. So since we can see all your names, I guess we thought that we would, I would allow I guess I could, or any one of the speakers could point out so I guess you have a feature, which is a reaction. You can raise your hand, or I guess I have a thumb thing. So if you have any questions, just go ahead, do your thumb, and then, we'll make sure to answer it. Oh, Fawn, Dr. Gordon.
Okay, so I have a question for Mr. Foerster.
Yes, hello.
Hello, how are you?
Doing well. Good to hear from you again.
Good. So I wanted to know, how does your work intersect with diseases of despair, the studies of Angus Deaton and Ann Case?
Diseases of despair was actually what I'm working on right now, as in I just wrote some of that yesterday. I thought that this actually blended really well with the idea of diseases of despair, because the articles that I was looking through defined like drug addiction and drug overdose rates as symptoms of a disease of despair rather than the disease itself, which I personally believe is probably the closest assumption to what the U.S. opiate crisis should be correctly identified as, rather than expressly a crisis in and of itself. To place it without that context, I feel ultimately detracts from its ultimate meaning within American society. So I very much agree with the concept of diseases of despair, and I plan on using them in my final chapter.
Okay. Sounds great.
Thank you.
Are there any other questions? Let me see. Let me look. Oh, Dr. French.
Hello, everybody. Thank you for the papers. Those were great. Really enjoyed them. I love that. I love the way you assembled the panel. Very bright and interesting way to think about these things as the connections between these papers. I wanted to just mention to Andrew, who I had a chance to work with him this past semester in the fall, and as this all was unfolding with COVID-19, watching the news coverage, it was just remarkable, because they had the Democratic killer line going for quite a while, and then suddenly you saw all this news coverage saying, wait a minute, there are disparities. And it was just like, oh, they just sort of woke up and started to see the numbers in the way that you were analyzing the numbers. And the next step is they're now talking about the spread to rural America, and I think the lower, poorer whites, and there's the South. I've seen articles just about the South generally, which would include poor working class people, black and white, and immigrant, Latino. I mean, it's so fascinating to see the way that the journalism has sort of trailed. And I don't know quite how to explain that, except that the historians weren't much help. You were, but you're one of, my sense is that you're making a very valuable contribution here, and that after your work is more popularly, known, that that myth of the Democratic killer will begin to erode, and the journalists won't be so quick to sort of adopt it. I don't know what were your feelings as someone who's following this coverage?
Thank you for your kind words, and it was great working with you. And again, like I said, that digital map is really because of Dr. French. But he won't take the credit, so I'll give it to him.
I will not. All yours.
Yeah, I think the issue with the journalism not really paying much attention to the history of pandemics and understanding that the impact will always be disproportionate to those that are marginalized and those that are impoverished. And in the United States is typically African Americans. I think it's two things. One is a historical thing. It's the fact that racists who seek to try and push the myth of a Democratic killer for their own purpose. Not that everybody who believes that pandemics are Democratic killers is racist, but almost all racists have the idea that the Democratic killer exists because they want to push the narrative that there is a hegemony. So you have a health officer, W.F. Brunner in Savannah, who says in 1914, 1915, that Black people are dying of tuberculosis and typhoid and things like that in the South more than whites because they their immune systems are weaker. And if we want to help them, we have to integrate them and assimilate them into white Southern communities and make them more white. If we can make Black people more white, we might be able to find a way around high mortality. And then you have people like H.M. Folks from Biloxi, Mississippi, who says, no, Black bodies their immune systems are very robust because they're savage and hardy and they're coming straight from Africa, where Africa is the dark continent, and there being all these different kinds of diseases. And if we assimilate them and put them next to whites, then we weaken their immune systems. They begin to dilute their good, hard Negro blood. At least that's what Folks is saying. But what Brunner and Folks have in common is that they're both scared of miscegenation. Okay, and that's the kind of thing that the dialogue is going on. So even eugenicists and racists don't come to a consensus about what do we do about Black mortality in the South. Black people are lesser because they're immunologically weaker, and they're lesser because they're immunologically hardy. They couldn't make a decision about which one it was. But the consensus was that Black people are simply weaker, and we will find a medical reason to highlight the weakness. That warped the historiography. That inability for eugenicists to come together and make a consensus about Black bodies in the South warped the way historians thought about it. And so they tried to push the narrative that it was a Democratic killer, the 1918 pandemic, or whites simply died more than African Americans. So I think that has something to do with it. I think the intellectual discourse on disease is warped by that early historiography laid out by eugenicists like Brunner and Folks. But I also think it has a lot to do with there's also the aspect of epidemiology that is very statistical and quantitative, and it lacks the qualitative context that history provides. And so when people see numbers, they don't understand the society that these numbers occur in. And when they lack the context, they make poor judgments about the pandemic. So I think it's those two things coming together that create this myth of democratic pandemics when they really don't exist. And we just simply haven't gotten to the part where, the interdisciplinary discourse is at the same time shedding the really vitriolic racial conversations that we kind of have in the American subconscious still. I mean, I read articles and people were sending me tweets that talked about Black people being immune to COVID. Right now, there is no there's no consensus about whether COVID confers immunity or not. People are being reinfected in China. And so, but they're quick to assume it because, again, that lingering racism, that epidemiological racism, still is hanging around and harassing African Americans. So,
Mr. Kishuni, can
yes.
you hear me?
Yes, I hear you
Okay.
perfectly.
Right. So, are you familiar with Harriet Washington's Medical Apartheid?
Yes, I have heard of it. I haven't read it.
Okay. But this is very similar to her thesis in that text, Medical Apartheid, as well as the Tuskegee syphilis experiment.
Yes.
So I just wanted to point that out to you.
Is that, I think, Bad Blood, I think is the book?
Right, certainly that's one of them.
Right.
Yes, yes. From 1932, the National Health Service, Public Health Service from 1932 to 1972.
Right.
Yeah.
The thing about syphilis is that it is in a pandemic because it doesn't sweep. And so when pandemics come through, the narrative shifts. But then when it's something like syphilis that early in American history has a certain moral assumption about the syphilis sufferer, then it's really easy to attach a stigma.
Yeah, the morality, theoretically, of it. Yeah. Thank you very much.
Thank you for your question.
I really like your analysis. Thank you.
Dr. Pineda, you were not, you are unmuted. Like, you're mute. Ugh.
Hi, sorry. I said if there are any other questions, and I wanted to know, I think these are students, Dana, Jesse, and Luis, if you have any questions for our speakers, or just general questions, or if you just want to talk about COVID. And remember, you might be muted. Okay.
And we could also ask if the students have questions for each other,
Yeah, that's true. That too.
the presenters.
So do you guys have, so John, Ediola, or Andrew, do you guys have questions for each other?
I don't have a question, but in the group chat, it looks like Jesse Campanella wrote Marines, Marauders, and Medevacs.
What's that?
I am unsure, but
Yeah,
there it is.
but he left, so he's not here anymore.
So, his parting words, I guess.
Yeah. I'm not sure what that means.
Well,
Yeah. So I'm gonna have a question for Ediola. So she has a question too. So Ediola, so unmute yourself. And what related to, you did talk a little bit toward the end about the LGBT community. So what would you say, like what got you interested about the LGBT and gender issues in your topic?
But certainly, like living in Albania, I grew up there, and like I know more like the culture aspect of like the and how those issues underline with the cultural aspects, and in most of the narratives and the readings, they are often not mentioned until the 1990s, when, like, you know, Albania transitioned after the 50 years of communism, where you were forbidden or you would have been executed and all the other things if you told your parents, or if the state realized that you were part of the LGBT community. And the main thing was you're supposed to be the alpha male or the alpha female who support the country and you do those great things for the country. So after the 1990s, when Albania was first presented with the issues of HIV and AIDS, and it started this underlying moral issue, like why is this happening? Why men who are married and like they are immigrant in other countries, they are coming with these diseases? And why, like in 1997, Albania was in like in a civil war, kind of, like most historians refuse to call it a civil war, but it was deadly, and a lot of things changed and happened during that time. So like looking at this perspective, and at the same time knowing the LGBT community, they were never given like not just not given a hand, but they were often judged, abused. And like when I was a student, like in Albania studying history, it really affected me how they were never mentioned in historical books, like neither before or during the time I was studying history. It was a modern era. We were not communism anymore. Like, why weren't they represented as humans, as part of the community? Why we were still holding these moral issues and not advancing in that aspects? So that was one of the reasons. And like my focus during the study in Albania was that, okay, substance use disorder was considered a plague, and knowing like how those groups were marginalized most of the time, how was affecting them, since like they weren't mentioned. And the only places where I found some information, except like my interviews that I did in Albania, was like the LGBT community. One of the papers they did to present to United Nations, and the other one was from the Axiom Plus organization. And like, how come when we have all of these groups, and why aren't we like experience, like being more normalized in like overall society.
Mm-hmm.
So like, and like, except like I mentioned, and for the like, except the LGBT community, like I mentioned for females too, like why we always hold this patriarchal rhetoric every time when it comes to females. Like, why aren't always like, wow, this is a horrible thing that females can do something like that? And like when the majority of the substance use disorder individuals are males, but somewhat is normalized because men can do those things.
Well, thank you.
I hope I answered your question.
You did. You answered
Because I took the longer route, like in order for, like, I know you are familiar with my work, but for everyone else who like,
yeah, like why be interested in that? And then I guess that all three projects also have something like the myths, right? The myth busting and lots of issues of race and gender. And Dr. French, I guess, sent us all an article. Is that about what we were just talking about, how the coronavirus affects the South?
Yes, yeah. I've just been noticing much more fine-tuned examinations, particularly of poorer areas, and they're starting to sort of pull this apart. I guess the question I had too was about the degree to which, this is a methodology question, I'm sorry, because I know we're sort of wrapping up, but I just thought about Andrew's work and whether or not this idea of using the mortality, I'm sorry, what was it, the mortality rate?
Yes, I use mortality rates.
Right, whether or not what you're seeing in terms of how data is being reported, is that being employed by journalists or public health people?
Now or in?
Yeah, now during this crisis, in terms, or it could be mortality rate or even infection rate, I guess would be another rate to look at.
The big problem, people tend to think that disease is really relegated to medical history, but it is also a political history. And this is the part where the politics comes in, you know, and that is the testing. We must know who is sick to catalog who is sick. And so a lot of people who have died maybe haven't been tested, and they don't fall into, and poor people who haven't had access to the testing sites. I mean, when you see something like, I read an article yesterday that said that the entire MLB was, you know, able to be tested. And most people hadn't even had symptoms. But when people have symptoms and cannot get testing, and then they die, which will ultimately, that will happen. Right now, it's growing and burgeoning into a big American pandemic. It's not at the level that 1918 was, and hopefully won't get there. But the issue, when every inch of America is covered with it, and everyone is getting sick, the issue will be who's going to fall into the reporting. So, for instance, in my New Orleans chapter, I highlight a guy named Walter Dodd, who visited New Orleans and did a sanitary survey of the city in May 1918, months before that second wave that I talked about earlier. So he doesn't get to see the big mortality boom in New Orleans, but New Orleans ends up being the third worst city in the United States to be in 1918. Pittsburgh is number one, then Philadelphia, and then New Orleans, a city with 300,000 people, squaring itself off against cities that have millions of people. And mortality in a city with 300,000 people beat out New York, it beat out Chicago, it beat out Baltimore, it beat out Detroit, it beat out every big city, except Pittsburgh and Philly, which were very close to New Orleans. Well, he goes to there, and the first thing he realizes is that for the amount of mortality that we're recording for Black people, for now that the New Orleans Public Health Department is recording for Black people, the testing for tuberculosis or for typhoid using sputum samples and things like that, the testing that's being done by the health department is enormously low. And so he's saying, how many African Americans in New Orleans are dying? We simply don't know, because of two reasons. They're too poor and too impoverished to get, and it's cyclical poverty. It isn't something that is, it's compounding all these different kinds of things. and that stops them from getting access to testing because they have to work their hand to the bone. The hospitals, half of them don't accept Black people, and those that do, they can't afford medical treatment. And charity hospitals that they can go to are closed during working hours, or I'm sorry, closed at night and only open during working hours. So charity hospitals are not an option. And so instead, they take the disease home with them and infect the families, and then infect everybody on the rail car, affect everybody at work. And so what Walter Dodd was advocating for was a paid sick leave. Exactly what we're seeing today about paid sick leave. Well, this is what Walter Dodd was talking about in 1918, the same year of the big pandemic. So reporting is his issue. And he's saying we don't know. From what we do have, it's obvious that African Americans are suffering way more than what we think, but we simply don't know how exactly that suffering is being distributed across the city because the numbers just aren't there. The testing isn't there. The people don't have access to the agencies that do the numbers.
Yeah.
And that would be the same thing with COVID, as long as the current administration doesn't do what it's supposed to do.
Well, this is an important point to make, I think, with digital history and the kind of data, right? The data we're working with historically, we have to be as transparent and careful in presenting it as you are in talking about it here, right? You have to make these same observations, and that's why the visualization can't stand on its own, right? It has to be annotated, explained.
That's the qualitative context that I was talking about, that a lot of these kinds of things lack. And so the assumption is made without any kind of contextualization. And so, oh, well, this is just the numbers. Let's trust the numbers because statistics can't lie, right? Statistics will always be correct. And that assumption is usually what not only warps the historiography, the scholarship is now kind of shifted, but also it gets people killed.
And on one other of these points, in terms of available data, one of your challenges was you only have county level, right? You had to sort of place cities in these counties to help us understand why certain counties might be, I mean, you can't isolate those cities, right? In terms of the way that the census, or the way that the mapping.
Yes.
Right?
Yeah, in Florida, the State Board of Health only reported mortality for all deaths and diseases at the county level.
Right.
So county morticians reported their mortality data to the government, the state government, and then the state government made their Board of Health report, and that's where it is. But it's very difficult to find city data. So,
but the good thing is that in terms of your mortality rate analysis, it's not affected by that because it's showing within group. And so where it happens, even though it's interesting to see, the where is useful as kind of a heat mapping.
Yes.
To what's happening in these counties where there are major cities.
Right.
But it isn't dependent on that dimension. Although, you know, it's frustrating. I think sometimes we say, well, if we only could show the cities, if we could break it out in some way, but we're limited in some way by the historical data and the data collection that went on at the time. So
Jacksonville has numbers, but you know, other cities, you know, Pensacola, don't have exact numbers.
Right.
And so you could do something on something like Jacksonville, but there would be holes in the thing. You wouldn't have the entire state as your sandbox.
Yeah. I had a question, a quick one. Actually more like a comment. So I know you're using Tableau, this is for Andrew, but also could you use Palladio that comes out of Stanford? And that one, like, it's also free, and then you punch in you just throw in all your data and stuff, and then if you had years or months, I guess in this, I'm assuming since they want it over time, I'm assuming you have data over months?
I have the data, I just haven't put it into that map.
Oh, okay. Yeah, so Tableau is fantastic. I love Tableau. But then another option is also Palladio, and you can see like the videos and what it does, and it does different things. So it does like time scales, it does a lot of different things that they're asking that really helps historians in seeing data. And it was created for historians, actually, because the director at the time was a historian, actually one of my former colleagues, Zephyr. And so when he was creating it, he was creating with computer scientists, but he was creating it as a historian. So it's one of these, so it's actually a pretty good program. And the nice thing about it too, because Zephyr knows historians, we're sloppy with data. And so you can literally just like scan all your data on an Excel sheet and just throw it in there. Just throw it into the little box, and then you get data inputs and stuff, because it just automatically recognizes like dates and names and that type of thing. It'll also tell you if you have errors, because most like historical data is very, or I guess what we call dirty, like when something missed values and all that. So it tells you exactly what is missing, because that's the most annoying thing in a lot of programs, is it just tells you it's missing. And I'm like, well, what is missing? And this one actually tells you what is missing. So that's how I was like actually able to clean a lot of my data early on because I had like 12,000 points. How many points do you have? You have 4,500 for that era. For Florida, how many, like, I guess how many data points do you have? Do you have like 5,000 cases, or how much?
So the data that I use is death data from 54 counties.
54 counties. Oh,
yes.
Okay.
And because of segregation laws, that data is split between total white and African American, which is good for me, because that's what I'm trying to show. I'm trying to show the differential mortality, but they did it because obviously the racism of the time.
Oh, okay. Yeah, of course.
The colonization. Mr. Kishuni, I also wanted to remind you that one of the reasons Katrina looked the way it did and New Orleans then in 1918 is because by 1840, New Orleans was had the largest slave trading market in the Western Hemisphere.
Right.
In the United States, I'm sorry, the North Atlantic. Brazil was still the largest.
Okay.
Yeah, Brazil had like 15 million people pass its ports, but it's true that the North Atlantic, it was one of the largest, yes. Okay, all right, we had 2 chats, actually, Dr. French, oh good, sending us, so yeah, so he sent you some of the, those visualization links.
One of them is Palladio, and the second one is called Flourish, which I've just started to notice a lot of the journalists are using. New York Times just, and the Boston Globe. And I asked Amy Giroux about this, and she's our DH guru at the Center for Humanities and Digital Research. And she says she likes Flourish. It does certain things that Tableau cannot. So it's worth trying these out. You know, it's good to know them all. I would try them all. I would check out Palladio and see what it can do and see what Flourish can do. I think Dr. Pineda is right about what I like about Palladio. Palladio is that it's created by humanists, open access, and for all good reasons, that's a great way to go. But I don't know what Flourish is. I think that some of these programs like Tableau Public and Flourish probably as well, there are certain limits to what you can do within the public and free version of it.
Yeah, I mean, there's a lot more you can do with the paid version, but isn't it $1,000 per use per year?
For Tableau?
Yeah, isn't it something ridiculous? That's
yeah, you take a look at the really nice ones and you say, I want to do that. And then you realize, oh, they paid for that one.
I know, they had it in Stanford at the Cesta Lab, but they have unlimited funds, so. Okay, all right, well, it's 6:15 and I know everybody's very busy and you have to go back to your COVID planning. But thank you so much to all the speakers. I guess we're all muted. So,
Thank you.
Thank you.
You can just do reactions.
Thank you, everyone.
All right, well, thank you, everyone. And it's recorded, so I will send it off eventually to Tiffany so that she can post it on YouTube or something. But you guys have, give her I think you have to give her your permission to do that if you want your likeness on it. Okay, all right. Well, thank you, everybody. Have a good night.
Thank you. Congratulations,
Thank you.
everybody. Thank you.
Okay, bye. Oh, and congratulations on finishing. Okay, bye.
Oh, thank you. Thanks.
Yeah, bye.